Hello, everyone. Welcome to today's National Neonatal POCUS Collaboratives webinar. My name is Sherry Baitang, and I'm from UC San Diego and Rady Children's. I'll be your moderator today. Before we start, I just have some general housekeeping items to mention. So first, the chat function is disabled for our general audience, but the moderators will send out general announcements through the chat. Second, audience, please use the Q&A feature to post questions. We'll answer those questions during the Q&A panel discussion. Lastly, this webinar is being recorded and will be uploaded to the Collaboratives website. So now to our main talk. So today is the third webinar in our Spring POCUS series, where we have been exploring cardiac POCUS in neonatology. So our guest speaker today is Dr. Gabriel Altit. Dr. Altit completed medical school at McGill University, followed by his pediatric and neonatology residencies at University of Montreal. He pursued his training in echocardiography scanning at Montreal Children's Hospital. Following that, he completed his postdoctoral research training in the pediatric echo lab at Stanford University, and also obtained a Master of Science degree in epidemiology at McGill. In October 2017, he joined McGill University and the Montreal Children's Hospital as a neonatologist. Since his appointment as a clinician scientist at the Research Institute of the McGill University Health Center, he has created the NeoCardio Lab at neocardiolab.com, which is truly an invaluable resource for those of us learning neonatal and cardiac POCUS. NeoCardio Lab is also available as an app on all mobile platforms. In 2020, he launched the McGill's Neonatal Hemodynamic Clinical Research Fellowship, which is a program designed to get trainees in applying echo techniques to research questions. So Dr. Altit, the floor is yours. Please take it away.
Thank you so much. And thank you so much for the invitation. It's really an honor and pleasure to be here. I will be sharing my slide and I'm hopeful that you're seeing them. And so really, it's really an honor to present for the Neo-POCUS Collaborative webinar and for the community, as I really think that the knowledge sharing and the amount of work that is being put for the community of POCUS practitioners and trainees is really incredible, and hopefully allowing to bring back this tool in some of your units to take care of some of the critically ill newborns that you care for in your centers and institutions. So today I've been asked to talk about one topic of cardiac POCUS, which is looking at patients with shock in neonatology. And so we'll address some of the POCUS evaluations and management strategies for shock, like the cardiogenic, distributive, and obstructive types of shock. And so I don't have any conflict of interest relative to this current presentation. However, most medications discussed have not been tested in the context of RCT in newborns. So my objectives today is really to talk a bit about some of the physiological concepts underlying perfusion and shock, and how can we use point of care ultrasound, and specifically cardiac point of care ultrasound, to recognize some of the different phenotypes that may eventually translate in a clinical picture of shock in our unit. So I'll go over some of the basic cardiac views that we use, at least in targeted neonatal echo, but I do think these basic cardiac views are the core of what you would do in a cardiac POCUS. And so we will often use what we call the parasternal long axis view, where you get a chance in that particular cut to see the left ventricle, mitral valve, left atrium. You get to see the right ventricle. And in this view, depending on your sweep, you can also access the RVOT or even look at the RV inflow. But when looking at the left ventricle, you already see or get a sense if the aortic valve is opening and closing, if you don't get some signs of blockage or obstruction below the aortic valve, like in infant of diabetic mother. You get to see if the mitral valve is opening and closing, which outlines the filling of the left ventricle. And you can get to see the posterior wall of the left ventricle and the septum kind of coming together as a sense of global contraction, at least at the level of the mitral valve and just below at the level of the papillary muscles. Then I'll change my view to the 90-degree of that, which is called a parasternal short axis, We call it a short axis because it's basically cutting the heart from on top. So it's looking from on top. So this time we see the left ventricle and we can see the two leaflet of the mitral valve, and we see the RV on top with the septum in between. Typically, when the RV pressures are lower than the LV pressures, your RV will have this crescentic form, and the LV will have a nice circular form at the peak of contraction when the aortic valve and pulmonary valve are open, and that the pressure will equalize with the corresponding outflow tracts. So this gives you a sense of, again, contractility at that level for the left ventricle. It gives you a sense of, is there a lot of fluid accumulating in the posterior area of the patient? So here, this bright white line is the pericardium. And you get also a sense of the interaction between the right ventricle and the left ventricle. You can use this view to sweep down and look more at the mid-papillary muscle view to get a sense of contractility of the LV kind of globally. Now we get in the views of the apical views, where you have here the left ventricle, the right ventricle, the corresponding atrium. This is a particularly important view to see the longitudinal contraction of the right ventricle. You can also get a sense of the left ventricular longitudinal contraction, which means going up and down and up and down. We know that the RV principally functions as a longitudinal contractile ventricle. The LV has a little component of longitudinal contraction, but the majority of its forceful contraction is coming towards the inside of the ventricle. We call this circumferential contraction. And in this view, you just get a sense, a bit of the filling of the RV, filling of the LV, whether or not these muscles are very hypertrophied, and whether or not if overall these chambers are contracting and relaxing appropriately. This is a view of the subcostal or subxiphoid. So here you have the probe, the liver under, and it gives you a particularly nice acoustic window to get a sense of the atriums. So in this view, when we do cardiac focus, it's a nice place to actually look for where your line placement is. And it's also a nice view to look at the relationship between the right atrium and left atrium for the flow between them, because most babies will have an interatrial communication. Now, this may be a bit more of an advanced view, but it's definitely information that becomes important when we do hemodynamics per se. And it informs you on the relationship between LE filling and RE filling, or RE pressure and LE pressure. And so you hear the flow is going towards the probe. So it's red by definition. So it tells you that this particular shunt is left to right. And then finally, I'll finish by one of the views we can get in the suprasternal area, which is really at the level of the neck. In that area, we like to see for the aorta, because in kids, especially if you have an unexplained cardiogenic shock, you want to make sure there's no coarctation. And at that point, you would have your cardiology service come in and do a formal assessment. But also for us, at least in hemodynamics, it's an important view just to get a sense of the structure called the ductus arteriosus, whether it is patent, the size of it, and the directionality of the shunt, which informs us on the relationship between what's happening in the pulmonary artery and the aorta. So the directionality informs you here that the blood flow is going from the aorta into the pulmonary artery. And so obviously this tells you that PVR are likely lower than the SVR at this point. So we'll go back a bit to physiology and think a bit more about shock. We know that shock is when tissues are not receiving adequate supply of oxygen to meet demand. And so because of that, we get a state of hypoperfusion, which can lead to ischemia and dysfunction of the tissue, and eventually necrosis, which is something we definitely want to avoid. And you can have compensated or uncompensated shock. That means that clinically, the baby is able to compensate to a certain degree by maintaining the pressure. But it doesn't mean that there's no status of hypoperfusion, even if the number of the pressure is being maintained, because the body will activate mechanism in order to maintain this kind of pressure within a range by activating secondary mechanism. And these mechanisms may lead, for example, to excessive SVR or to forceful contraction to increase stroke volume, and these may lead to secondary effects. Now, we know that having a good perfusion means that we want an appropriate oxygen nutrient delivery to the demand that is required metabolically. You don't want to have excessive perfusion, or you don't want to have underperfusion. So we know situations where you have, for example, hyperlucency phase in HIE is just an example where you can create damage in your brain if you have too much flow going. And if you have underflow state, you can also create some issues. So you want to find kind of this nice balance. So typically the clinical presentation of patients who are in shock at the bedside, obviously blood pressure is often a late finding because it's, as I said, something that the body will try to maintain. The two level of action for pressure is acting on the resistance of the system or the degree of flow through it. And so if this drops, pressure can drop. If resistance drops, pressure can drop. And if you have a drop in resistance, increase in flow, you can maintain your pressure. So when looking at blood pressure, you always have to take into account these components, as well as which blood pressure you're looking at. Is it the systolic peak? Is it the diastolic, or whatever is being maintained in the system during ventricular relaxation? Are you looking at the average value throughout one cardiac cycle? And where is the location of this pressure and the values, and how do they interrelate when you're looking at pre and post ductal blood pressures? And so it's important in patients that trends more than absolute numbers will give you more information. And if you have like quote unquote low numbers, it's obviously important to put them into context, knowing that some babies may have different ranges of pressure and still perfuse adequately. And so the other markers we'll look at bedsides are obviously heart rate, which may be influenced by, for example, things that we do in the unit like therapeutic hypothermia or medication that we use that are chronotropes, as well as some babies who may have neurological injury and can have issues with their heart rate, or seizures that can influence heart rate, or pain. We would look at the capillary refill time, which can be affected also by certain things like autoregulation or maturity level or therapeutic hypothermia. The pulses, the liver edge, which informs you on if there's high right atrial pressure, because if there's high RA pressure, for example, due to RV failure, your liver will be congested. Finally, there's other things like cold to touch, being mottled, and abnormal body temperature. But all of these signs are often quite subjective, and on top of it, they may be kind of end results of a process that is ongoing. And that's why it's always important, or always a nice thing, to be able to complement your assessment by having direct physiological information, such as using POCUS to get a sense of what's happening underlying. Now, we do have certain tools, like, for example, looking at the urine output, lactate, and gases to see if there's ongoing organic damage. But these are late markers, and it means that there's probably already situations of hypoperfusion to the kidney, for example, or to other tissues. And we know that there are certain processes that will have a concomitant, like acute kidney injury or immaturities of the kidney. And so some of these markers may not be the best ones. So we said that pressure is a function of flow times resistance. Now, in our words, it means that the global blood pressure of the system is related to the cardiac output times the overall resistance of the system. We'll try to deconstruct these pathways. We know that the blood pressure is a pulsatile blood pressure in humans, which means that we have the systolic phase at the peak of contraction, and a diastolic phase, which is when you get ventricular relaxation and you get closure of either the aortic or pulmonary valve, whether you're looking at the pulmonary system or at the systemic areas. And so what you're maintaining in terms of pressure will be dependent on the competency of this valve, the vascular tone, as well as if you have a steal. And the steal could happen by a structure like a duct, or aortic valve insufficiency, or a vascular malformation, but it could also be a steal secondary to bleeding, for example. So when you're looking at these pressures, important to keep in mind the whole cardiac cycle, and what we're measuring in terms of a mean blood pressure or mean arterial pressure is obviously the area under this curve, because we're doing the average of all these little values here. And so when you're looking at the numbers at bedside, it's important to keep that in mind, and important that our two systems might be quite different. And that in babies, what's fascinating is that you may have a communication in between, which can also change how the different resistances and output will behave. So if we look at cardiac output, it's usually a function of stroke volume times heart rate. You know that in babies, stroke volume can be influenced by many factors. Typically, the three factors that we think about is contractility, preload, and afterload. Contractility is definitely something that changes a lot in the NICU based on the babies you'll be treating, because premature babies may have a different myocardial maturity than a term infant. You may have also situations like infant of maternal lupus or infant of diabetic mother that may have different properties of contractility. Preload can be affected by the lungs, by tachycardia, by having smaller ventricle. And finally, afterload may also be influenced by situations like preeclampsia, which can lead, for example, with vascular stiffness. Heart rate. Heart rate is something that we can typically directly measure. Stroke volume is much more difficult to measure. We can estimate it by echo, but heart rate is something we can actually see, and often something that will react when it's sensed that the stroke volume is dropping in order to maintain the cardiac output. And this can be influenced a lot by both the autonomic nervous system, but also some of the medications that we use. So when we look at the three standard view that I have already previously shown, this is like a baby with a normal cardiac function and normal filling. So we see here the parasternal long, parasternal short, and apical view. And we can see that there's these two walls that are not kissing, and they're not kissing in any of the views, that the LE is nicely filled and RE is nicely filled. So the LE doesn't look overfilled or underfilled. And that you don't see any kind of big fluid around. So it tells you that there's relatively nice filling, relatively nice contractility, and this valve opening and closing tells you that there's forward flow. So when I'm looking at resistance, I'm often looking at the total peripheral body resistance, but obviously, as we know, it's the sum of all of these local resistances that may change by autoregulation, and the brain is very different than the kidney, for example, thankfully. And these total peripheral resistance can be greatly affected by inflammation, autonomic nervous system, and some of the therapies that we provide to our babies. Resistance is, small to a very small degree affected by viscosity. It's often something that we don't think about, but in very, very profound anemia, resistance will change, such as fetal maternal hemorrhage with a very, very low hemoglobin. And then finally, the total peripheral resistance will obviously be altered when your pulmonary vascular resistance and your systemic vascular resistance are actually interconnected by a big shunt. So as I mentioned, when we come at bedside and we're being called for hypotension can mean so many different things. And so that's why I think cardiac POCUS provides you the opportunity to better elucidate these different kind of component of the equation by getting a better sense of what's the contractility and your heart rate, and what's your cardiac output, your filling, your stroke volume, and things like that, in order to be able to understand what am I going to act upon. Now, we know many preemies, for example, will have low BP numbers, and it doesn't mean that they're actually having hypoperfusion of their structure. So it's important to keep in mind that the first thing we want to do is first establish whether or not this number is something that is leading to concerns clinically to organ perfusion. So when we're called for some of these patients and that you do have established concerns about low perfusional status or ongoing deterioration towards a low perfusional status, you are in a situation that you're probably having a shock. And so you want to establish what is the therapy you're going to be actually addressing, because you want to avoid overflooding your patients with volume when it's unnecessary, or you want to avoid giving agents that would address a distributive shock to a patient that has, for example, a cardiogenic shock, because in distributive shock, you will increase your resistance, and that's not something you want to do if you have a cardiogenic shock when the left ventricle is already struggling to pump, and now it's going to have to pump against even more resistance. So that's why I think that cardiac POCUS can inform you better when you're making these critical decisions at the bedside. So in which situation you should start thinking about the possibility of a cardiogenic shock. Obviously, your physical exam will already give you a lot of sense into that. If a baby is very cool to touch, very prolonged capillary refill time. But even beyond that, and before we get to that state, you have to think about situation like asphyxia, where you could have coronary hypoperfusion or myocardial hypoperfusion. Situation that may make you suspect cardiomyopathy, like in Noonan or infant by diabetic mother. situation where you may have myocarditis or fibrosis, like in certain types of infections, or in infant of mothers with rheumatological conditions. Arrhythmias can lead to eventually a cardiogenic shock, especially if there's been protracted SVT or PGRT, which sometimes is unrecognized because the baby might be home and arrive under your care at 2 to 3 days of life. Obviously, left-sided obstruction, coarctation, interrupted aortic arch, you would start seeing low femoral pulses and often differentials of SATs as the PD is closing. And then situation with metabolic disease. So when you have a patient in shock, always look at all of these other factors like your electrolyte balance, whether or not there's hypoglycemia, and looking at your calcium levels. So how does cardiogenic shock would look on your cardiac focus? Well, this is obviously one extreme example. Again, you can see the RV and the LV. We see the tricuspid valve and mitral valve open and close, but we can see that there's almost a cardiac standstill where these walls are actually not coming together. I typically look at every segment of my ventricle where I actually put my hand on the screen and I hide the septum to look at the free wall, and then I hide the free wall and look at the septum, and I hide the upper part of the heart to look at just the apex, and then I look at just the upper part, just so that my eyes can look at all the subsections. But I can tell you that this LV looks like having a global cardiogenic issue. We can even see this time on the RV that this tricuspid valve is barely moving. And so in this context, we can see that there's profound RV dysfunction. And so we'll talk a bit more about the therapy of these patients, but typically this is a patient I would want to maximize anotropy, decrease cardiac metabolic demand, make sure that we don't have situations of arrhythmia, maximize my calcium level if it's low. And these babies may need to be intubated carefully, but the idea would be to remove any kind of work that this heart has to do. Hypovolemia can happen for various situations. So on history on exam, you would have suspicion of hypovolemia as a cause of shock. If you had a history of, for example, placental event or cord event, acute fetal maternal hemorrhage, so think of sending your KB test, a volume loss during surgery, or you may have a clear history of a sacrococcygeal teratoma which has ruptured, and trust me, when you have that, you want to call your blood bank to activate a massive transfusion protocol. Internal bleeds can happen too and can be quite profound, like severe intracranial hemorrhages or IVH in some of the preemies we see, subgaleal hemorrhage, pulmonary hemorrhage, surgical, traumatic, or even think of shaken baby syndrome if this baby has not been monitored, in-house or has been home. Third spacing can also be a cause of hypovolemia. So, sears or inflammatory situations like neck or sepsis, situations with pleural effusion, hydrops, ascites, dehydration from renal tract or GI tract, or situations where you have complex physiology like TTTS, which the receiver twin has been very dependent on receiving a very high preload. And so postnatally, if you don't give enough, you might end up in a situation of being preload dependent. We know that our babies being born less than 25 weeks often have profound renal losses in the first few days. And so that can often lead to some degree of hypovolemia if there's not enough replacements. And finally, severe hypertrophy of the heart can be quite preload dependent. So these patients will have typically, this is an apical 2 chamber view. You see this is the left atrium, the posterior wall, anterior wall of the LV. This is the apical 4 chamber view. And they'll really have these kind of kissing ventricle where the free wall and the septum are kind of touching and abutting each other. And often even the right atrium looks very tiny just because the preload is very tiny. Sometimes by cardiac focus, you can also look at the IVC. And if the IVC is completely collapsed, it gives you a sense that, there might be less filling. The issue with IVC is that it might not be collapsed in a situation where you're intubated and you have positive pressure in your chest for babies, which is often the case in these patients. And so having an open IVC that is poorly collapsible doesn't tell you that this kid is necessarily underfilled. So you have to be a bit, caveat to that. The other thing that you can look at for more advanced practitioner is getting what we call LVOT pulse wave Doppler, which provides you a sense of the cardiac output. And these patients, because they just have poor ejection being underfilled, they'll have very low velocity time integral, which is a marker of stroke distance. Why is it called velocity time integral? Is that here you have the time, you see the QRS, and here I have the speed, and this is the speed at exactly where I put my cursor, which is at the zone of the left ventricular outflow tract. And if I do the area under the curve or the integral, it provides you a sense of the stroke distance. We can have situations of distributive shock. This is when you start having a loss of systemic vascular tone. And typically these patients will be hyperdynamic. So they may have a component of low preload, but at some point when you filled in the tank, they may also have a large component of low SVR. And because of that, they have low perfusion because first of all, their resistance drops. The flow tries to adapt to maintain blood pressure. But when you see the pressure starts tanking down, it means that the flow is not able to compensate. So these are situations where you often have like neck sepsis, or it could also be adrenal insufficiency, thyroid storm, or more rarely STSS type of syndrome. And typically what you want to act is give a vasopressor like Norepi or vasopressin to support the systemic vascular resistance. So they will look like this. They'll often have very hyperdynamic tachycardic heart, where you can see that the heart is just extremely hyperdynamic. Here it's like a short axis in the subcostal view or short axis in the parasternal view, where you see this very hyperdynamic, high heart rate type of heart in a clinical situation where these patients have kind of a flash refill and very warm to touch, very red clinically. Finally, the obstructive shock is typically a situation where you have either an intra or typically extracardiac situation of impaired cardiac output. So we often think of tension, pericardial tamponade, or constrictive pericarditis that could happen with infection. That's much rarer. Or we can think about tension pneumo, and more rarely in babies, things like very, very high pulmonary hypertension or pulmonary embolism. This is very rare, but you can think of in patients on VAD, for example, they can have that. So a tamponade would look like this. Here you see a lot of black fluid surrounding the heart, and you can see that the heart is kind of dancing in the big pocket, which is the pericardium, which appears very bright here. You can even see the flap of the right atrium being a very low pressure structure. And so when the pressure becomes very high outside of the heart, you can see it kind of flap during the cardiac cycle because the pressure is higher than the right atrium. And this is really a filling problem. It means that the pressure is so high around the heart that the ventricles are being collapsed and the atriums are being collapsed. So the filling is not able to get to the ventricle, and eventually it drops the flow and it drops your pressure. So you get a poor cardiac output syndrome. And the solution is really to drain in that situation. You have to be careful because it's not all the pericardial effusion that will lead to tamponade physiology. But when they become circumferential, global, and you start having hemodynamic effects like fast heart rate and low blood pressure, that's definitely because you probably have low output. Acute PH would appear like this. So this time you can see that this LV is not nicely round at the peak of systole. You can actually see that the septum is bowing. That's because the RV is facing a very high pulmonary vascular resistance. And in that particular pulmonary hypertension physiology, it's kind of an obstruction to output, and you get low pulmonary blood flow and then eventually less left atrial preload. And this can lead to eventually less LV preload and poor cardiac output. So depending on the type of acute PH that you have, if it's a high pulmonary vascular resistance type, then obviously you would act on that by trying to decrease the pulmonary vascular resistance with appropriate ventilation and sometimes even pulmonary vasodilators. So management or therapy, once you have kind of your phenotype using cardiac focus, well, you must address the underlying cause to reverse the process, which means supporting the ventilation, the oxygenation, and organ function. Sometimes it's antibiotics, sometimes it's addressing adrenal insufficiency, but it's trying to put all together the piece of the puzzle and really addressing the sources of the issue. Now, cardiogenic, you obviously want to eventually support the heart, but you have to think about what is the first etiology of the primary cardiac failure. So inotropic support are typically dobutamine, epinephrine, sometimes milrinone if your BP is being maintained and your urine output is adequate. Things like decreasing metabolic demand is something we already addressed, and in certain situations is to decrease the SVR if you're not hypotensive. Hypovolemia, you want to give volume, antibiotics or anti-inflammatory on the etiology. Distributive, you may want to give a bit more volume, but once you maximize the preload and volume on your Frank-Starling curve, then you need to adjust the SVR by giving medication that will increase your systemic vascular resistance, like norepi and vasopressin. And finally, obstructive, it's typically by draining the obstruction if it's an extrinsic, or if the obstruction is something that is intracardiac, like a PE, then you obviously need to address that with kind of a more specialized team. It's something more rare. I've put this great table that Dr. Satyan actually shared with me. I just find it nicely represented where you have pulmonary vasodilation and pulmonary vasoconstriction on one side, systemic vasodilation, systemic vasoconstricting on the other side, and kind of the effect whenever you're supporting your heart. And so whenever you're looking at you have your physical exam and your history, you got your cardiac focus, you've outlined your phenotype and your physiology, and you're at the step of trying to choose a cardiovascular agent to support your heart and your vasculature, I would say using these kind of approach helps you making the better decision about which agent to use, because you do want to avoid having the side effect of these agents and you want to avoid the polypharmacy. So if you're trying to pulmonary vasoconstrict and increase cardiac function, you may want to use something like epi or dopa. If you're looking at strictly providing cardiac support without having an effect on pulmonary vasoconstriction, you may want to use something like dobutamine or even eventually milrinone. And if you're looking at increasing your SVR, you're probably going to be more at the vasopressin or epinephrine kind of effect. The part that's not there is that you have to be aware that some of these medications will also affect the heart rate. So things like norepi, epi, dopa, and dobu will increase your heart rate because they're chronotrope. So if your baby is already very tachycardic, it's something you want to keep in mind. I've put here, I'm not going to go over for reference, that's my cheat sheet, which includes all the drugs and their effect on inotropy and systemic vascular resistance, and something I kind of look at 3 a.m. when I'm desperate and I don't remember anything on how to manage my patient. So it will be available in the slides following this presentation. And I've put exactly the same information from a paper by Dr. Shiran Moore on these agents and their effect on heart rate, contractility, SVR, and PVR. So the beauty of neonatology is that the babies come to us and they're very resilient, but they often have mixed pictures of shock and hypoxia. So we spoke about acute PH, which are situations typically of high pulmonary vascular resistances. And because these babies have shunt, they may shunt right to left at the PDA and atrial level, which will make these babies blue, both on the pre and post-ductal component. So this will typically look like this on the echo. I think I have 5 minutes left. Okay, perfect. Yes, I'm being told yes. So these patients will have typically some degree of RV failure, but non-dramatic if the PDA is open, but they definitely will have signs of high RV pressure compared to the LV, either within an isosystemic or suprasystemic range. And so typically these patients, and that's a paper by Dr. Gissinger, who's really outlined what to do when you have acute PH in these babies, is really optimize the ventilation and provide some degree of pulmonary vasodilation. If the duct is closing, then your RV may start struggling. And so these babies will look a bit more like this, where the RV is a bit more poorly contractile. You can see it here. There's a bit less motion longitudinally of this RV, and the RV looks a bit more distended. And on the short axis, you can see quite a dilated RV, which is about the size of the LV with a kind of bowing septum. So these patients with RV dysfunction PPHN, which often have restrictive duct, the first line are often to support the RV function and provide some degree of pulmonary vasodilation to decrease the afterload of the RV, but sometimes you do have to reopen the duct. I'll go on with LV failure. These patients particularly have high LV and diastolic pressure, so typically they have a left to right shunt at the atrium. So preductally, they'll often saturate nicely unless they have lung disease. And then because their LV has poor output, if their PD is open, the RV may contribute to the LV systemic flow. And so they may present with pre and post ductal saturation differences, but these are definitely babies where you're happy to have the right to left shunt at the duct because it provides perfusion. So they will typically look with this, very significant left to right PFO, but they have right to left ductus arteriosus flow, and their LV looks completely stunned. So these are babies you want to do what? You don't want to start INO because they have very poor LV function and poor LV output. You want to support this left ventricle by providing inotropy. So these are patients you want to give either DOBU or epi, and sometimes even consider PGE if the duct is closing. And then sometimes you have biventricular dysfunction. And obviously in these patients, I'll skip this. In biventricular dysfunction, again, your first line is inotropy. And if you start, not being able to reverse the process, you may lead to go to ECMO. So quick case, you're called bedside for a patient previously on CPAP. He's crashing apneic. Your BP cuff is with a narrow pulse pressure. Pulses are very weak. You intubate without pre-med. You do your POCUS, and you can see that there's like significant pericardial fluid. And all the views, you can see this kind of circumferential black fluid around the heart. You use the CHOP algorithm, which I've put here, which outlines, at 3 a.m. what you want to do when your baby's crashing with pericardial effusion and tamponade effect. You drain, you get some TPN out, and you can see that even this PICC line is still floating in the heart, and now the heart looks much better, and you're very happy. You do your subcostal view. This is the IVC right atrium, and you can see you have this kind of floating catheter in the middle of the heart. So you want to pull this catheter because this is probably the culprit of your situation. The second little case is you're at 3 a.m. in the NICU. You feel like this, but I'm going to tell you, let's chill and figure out what we're going to do. Basically, you're being called, there's a baby with septic shock that's going to die. Please, please, please help me for a consult. So I say yes. I'm being told this baby's already on DOPA, norepi, hydrocords. The BP is very low. The heart rate is very high. This baby has already been intubated. I'm being sent the gas, which is quite concerning, 715 -8. And the person has done a bit of a cardiac POCUS. So what do I see? I see, very kissing ventricle, very hyperdynamic heart, cardiac function of both the RV and the LV that looks pretty nice. This is compatible with warm shock, but this baby's already on norepi. I'm asking, what's the status of your PDA? I'm being sent a view of the duct, which doesn't show a duct. So the duct is closed. And eventually I'm looking at all of this and I put together, well, this patient has no PDA, has a good function. The heart rate is very high. Now that's a problem. I want to act upon that. And so I look at my table. I say, well, this patient is already on 0.2 of norepi. So where am I going to get at? I'm not able to maintain my perfusion pressure because the BP is dropping. That's probably because my resistance is still too low. My baby has a flash exam. What's going to be? Well, I need to maximize my volume status. I need to act on the low SVR, but I need to make sure I don't increase further my heart rate, which may decrease my filling. So what I'm going to choose is actually to give a bit of vasopressin, which actually does not act on heart rate. And so I recommended to decrease my norepi and introduce vasopressin, stop the dopamine because of the very fast heart rate, and then maximize the fluid status. And what they've sent me is the blood pressure that increased throughout the night and the urine output that we started on this baby. I asked on the Friday, is the baby better? Yes, out of shock, weaning all inotropes and pressors. So I think that now at 3 a.m., you would be able to recognize that a baby in shock with this picture on your cardiac POCUS view has a cardiogenic shock. And hopefully you'll retain that you're able to act on the physiology and provide the best care for these babies. So POCUS can help identify cardiovascular phenotype in shock situation. I think you need to remember that BP is a constant of flow times resistance when you act upon it. And then finally, I think that cardiovascular support based on physiological phenotype is probably the best we have so far until we get better RCTs providing us with clear treatment algorithms that changes outcome. So I'm open for questions, comments, or insults, and I've put here my contact information and a QR code to my website where you'll find a lot of these resources and presentations.
Thank you, Dr. Altit, for such a wonderful and engaging talk. We will now move to our Q&A panel, expert panel discussion. So audiences, just a reminder, please put any questions into the Q&A feature and I will relay them to the panelists. So joining us today, we have Dr. Bambal, Dr. Levy, and Dr. Ruals. Dr. Shazia Bambal is an associate professor of pediatrics at Emory University and the vice chair of the National Neonatal POCUS Collaborative. She's a member of the Pan-American Hemodynamics Groups and the Targeted Neonatal Echocardiography Special Interest Group within the American Society of Echocardiography. Dr. Phil Levy is a neonatologist at Boston Children's Hospital and an associate professor of pediatrics at Harvard Medical School. His academic focus is on neonatal hemodynamics. He is a clinical liaison between the Division of Newborn Medicine and the Heart Center at Boston Children's. Dr. J. Lauren Ruals is a neonatologist and neonatal hemodynamic specialist at Orlando Health, Winnie Palmer Hospital for Women and Babies. She is a practice director and the division chief of neonatology at Orlando Health, Arnold Palmer Hospital for Children, where she is developing their neonatal hemodynamics program and funding their POCUS program. So thank you all to our panelists. So the first question we have is, at your institution, do you have a standardized approach for using POCUS for shock?
I will let my colleagues answer.
We do not have a standardized approach for using POCUS for shock in my institution. Currently, the main way that we are utilizing POCUS is for emergency assessment of the crashing neonate, but are working through processes to discuss how best to utilize cardiac POCUS and then when to flip to echo in management of shock.
I'll go next. Similar to what Lauren had mentioned, we don't have a standardized cardiac POCUS algorithm, but in collaboration with the efforts that Shazia is leading and Lauren as well, we're working on both developing the standardization as well as the credentialing approach, knowing as Gabriel highlighted that cardiac POCUS is obviously different than targeted neonatal echocardiography, but there is a extreme need to develop standardization around cardiac POCUS that not only involves training at the attending level, but also infiltrates into the fellowship level as well. So this is a high priority, I think, for everybody.
Yeah, I would agree with that. I think standardization and trying to identify the views, like as Gabriel had pointed out, to know how to obtain views and try to see as much normal as you can. Because quite frankly, I think none of us want to have a patient that is decompensating and dies without having an ultrasound on that could potentially identify and triage patients faster to diagnoses such as a pericardial effusion that could be intervened on, or a heart not working or not, I think that's what our goal is for cardiac POCUS. Sometimes even just teaching views is doing a subcostal view where they could obtain a lot of information from even one view. So identifying also within the institution what makes sense to work on may be part of the protocol that's development. But as Phil said, hopefully we'll get some more guidelines with that upcoming.
And I'll just add one additional thought process. I think a common question that the four of us get are, what are your guidelines? What do you do A, B, C, D, E, and F? And Gabriel did a really nice job outlining the views. And you could start with the views, but you're probably, missing the bigger picture. And what we try and focus on is, what are your indications for cardiac POCUS? And for us, and I've written it down so we don't kind of veer from that, but it's really, the central line placement, pericardial effusions, hypovolemia, and then underperfused states. And it's really nicely outlined in the recent guidelines, 2024, the American Society of Echo guidelines that talk about targeted neonatal echo, but there is a really nice section on cardiac POCUS. And what we're hopeful from this group and other groups is to develop a more rigorous focus on cardiac POCUS that also then is matched by evidence once we have some reference tool or guidelines in place. So starting off with the indications for the cardiac POCUS will guide you towards the great algorithm that Gabriel presented, and then we'll take you to the management strategies.
Maybe I can just add one thing, Sherry. So locally, at least in our institution, what we try to do is that yearly we run a multidisciplinary POCUS workshop. And I found that this was a very nice way to kind of collaborate across the different divisions. So we have like ICU, cardiology, radiology, anesthesia, NICU, and pediatric surgery for the trauma service to come together. And we do a 2-day workshop where all the fellows that are starting in our institution come in for 2 days. Not that 2 days is enough to learn like POCUS, but it helps like standardize the process, and knowing that we have also expert in the room like cardiologists and radiologists to help us with some of these stations. So 1 day is like related to kind of the core concepts, and then we have a day with practice on standardized patients, and then 1 day is like simulations, and these simulations are made with the group contains one NICU fellow, one PICU fellow, one surgery fellow, one anesthesia fellow. So they kind of work together and get to know each other. And so we do scenarios like the crashing neonate, the trauma bay, the emergency room, and it helps kind of just understand the reality of everyone, and it gives a sense of kind of POCUS skills. And then fellows are invited to go back to their different unit and to actually work under supervision of different experts to assess patients when we have states of hypoperfusion, like Dr. Levy mentioned, or of line placement and things like that. The issue we do have, and I think many of us struggle across North America, is that each center will have maybe 1 or 2 experts. And so for supervision, it becomes a bit harder, and especially implementation. But locally, what we have tried is that one of our new colleagues is really trying to implement like capsules of learning, even for the attending, so that everyone is kind of ramping up their skills and knowledge. And we're limiting it to kind of the indications that Dr. Levy mentioned. And that's really with always the constant support of having these experts, either in hemodynamics, cardiology, or radiology, that come in and supplement when needed for some of these patients. Just because realistically at 3 a.m. when the baby's not doing well, we get these information in order to act upon, and eventually we get more formal information from these kind of specialties once we get access to them.
So thank you. Actually, talking about standardization and also this idea of training our eyes, one audience asked, has there been studies to look at accuracy of assessment of contractility by eyeballing versus actual measurement and the decision of ionotropes in acutely sick infant?
Is that a question for me, or someone else wants to jump in?
Anyone, any takers?
Go for it, Gabriel.
I think, for me, I think, all measurements are very important, especially when you're going to start tracking the effect of certain therapies you're going to put in place. We know that babies are very dynamic and hearts are dynamic. I see it, and it might be a wrong way to interpret it, but I see a bit like, what we do on the respiratory standpoint. What's happening with your oxygen? What's happening with your mean airway pressure? What's happening with your respiratory rate? Is the baby like breathing or not? But you're also looking at your baby. Is my baby, in distress or not? Is there work of breathing, retraction? So these things are dynamic. And I think the measurements provide you with more granular information of how dynamic these things are. And they allow you to provide you like a nicer picture or story. But I would think that the patient who's acutely decompensating at 3 a.m., if you put a probe and you see a standstill heart, like I would hope someone is able to recognize this. I think measurements becomes more important when you start looking at more subtle changes, or even, not so subtle, but you have some degree of biventricular dysfunction, but you want to understand what's the predominant, phenotype, or what's the predominant ventricular kind of dysfunction. And it helps with the tracking and response to treatment. But for initiation of therapy and recognizing these different pictures that I have outlined, I think the eyeballing method just provides you with this kind of early onset information. And when you want to get the more advanced assessment, that's when I would get, hemodynamics, cardiology to come in and provide with this extra support. I'm not aware of any great studies looking at eyeballing versus not. I know that there's been some papers looking at variability between telling if it's a good or not good cardiac function versus what the measurement will tell you. So you may think your RV function is like quote unquote normal, but actually when you measure the specific metrics of RV systolic function, you realize that the RV is actually struggling. But also if you look more at, like, for example, an RV that has like a lot of tricuspid regurg, then the RV is pumping against the right atrium. So obviously it's very easy for the RV to pump. So the contractility may look perfectly okay, but it's actually pumping reverse, right? Like epstanoid valves, for example. So you have to be careful also to not overinterpret normal or underinterpret normal. So it's kind of, you still need to build your experience. And I would say that sadly, there's still a lot of subjectivity to when you're eyeballing things. But I think the overt cardiac dysfunction or overt hyperdynamicity, you would notice it on quite quickly on a cardiac POCUS. I talk a lot. I'll let my colleagues speak.
No, it's just to kind of go along with what Gabriel was saying. One of the things that we were just recently talking about was that cardiac POCUS is more the qualitative assessment, whereas targeted neonatal echo by pediatric cardiology, that's kind of more your quantitative assessment. And so we want people to be able to look and see severely depressed versus normal, those kind of markers of mild, moderate in there. Really what you want to be able to see with cardiac POCUS is the heart part of the reason that the baby is decompensating? Yes, no. I'm doing an intervention. Did that make it better? Yes, no. And so while measurements are very important, the eyeball test, I think, when you're talking about cardiac POCUS, is a lot about what we're discussing. The VTIs, Gabriel, that you were mentioning, I was actually just talking with Shazi a little bit about this. So I don't routinely teach that as part of cardiac POCUS. That said, VTI is something that is really good from an eyeball, where even if I don't measure it, I can tell just when I Doppler if it's just a little bump or if it's a really good Doppler there, that the cardiac output's going to be super, super low or the cardiac output's going to be super high. And I can tell that just by eyeballing. So I'd be interested in this kind of group's commentary with the Surviving Sepsis campaign saying high cardiac output goes along with warm shock, and we should really be looking at some of those echo markers. And granted, they're looking at pediatric patients. What do we think about the eyeball of the VTI, not the true kind of quantitative measurement, to say, okay, does this fit more with warm shock? When I intervened, did it make it better or worse? Or do we think that's still going into that too much in the quantitative realm?
Yeah, I mean, I do think the pediatrics world does use and it integrates VTIs, aortic VTIs, in a lot of their hypovolemic measurements, and not necessarily the absolute values per se, but also for changes as you're referring to. And there is some literature on eyeballing. It's more, there's in adult EDs tend to have some, and they talk also, as you're talking about eyeballings, have some training beforehand, and some of that will outline what kind of the training and going along with cardiology and how it quantitates it. There is some, and sometimes, as Gabriel mentioned, the measurements are great for looking at, but the measurements don't always match up as well with that as some of the eyeballing for the bigger variations.
Yeah, I think it goes back to you mentioned that there, as we develop our guidelines and reference tools, there's going to be a basic cardiac POCUS and probably an advanced cardiac POCUS, which is still different than targeted neonatal echo. And I think within the advanced cardiac POCUS, I could envision something like the VTI being a part of it. And then I think to answer, the question just in general, and for me, I like to go back to the physiology. It's really, are we dealing with preload, contractility, or afterload? And the use of cardiac POCUS with the eyeballing and to Lauren's point, do you have normal function or, obvious cardiac dysfunction? That would help you tailor your pharmacotherapy approach. So if a baby is hypotensive and you put the probe on, but you have pretty good function or hyperdynamic function, and it fits in a state where vasopressin could be more useful than dopamine, dobutamine, or epinephrine, then that would give you kind of some sense that you could be using the vasopressin and not worried about there being abnormal cardiac function. Conversely, you may realize it's a volume issue and have to give volume. And while we haven't done a study with cardiac POCUS, some of the earlier work out of Iowa with T&E echo, where they had hemodynamics program before and after, they did see a change in how they are managing the extreme premature babies who were presented with hypotensive, where they were giving much less fluid and more inotropic support post initiation of a hemodynamics program. Now, again, T&E echo is different than cardiac POCUS, but I could envision in your own cardiac POCUS world where you develop a cardiac POCUS program, that's the type of research and clinical-based question where you could see real-world quality improvement metrics. So I just think that that's where we're heading for the field.
Okay, no, thank you. That is very helpful. I think regardless, for those of us just starting echo learning this, we should definitely train our eyes for the eyeballing to gain more experience. So the next couple of questions are very specific about choosing ionotropes or treatment. So the first one is, in the setting of biventricular dysfunction with acute severe PH, which ionotropes do you go to first, including INO?
So for me, it depends. When you say severe biventricular dysfunction, does it look like it's a primary RV phenotype or is it a primary LV phenotype? And that's when you're, in my mind, leaving cardiac POCUS a little bit and going into more of those defined quantitative markers that you're looking at in echo and TN echo, because you're trying to figure out which ventricle is primary. And it's hard to do, I think, with cardiac POCUS alone. What Gabriel was showing in the training that he has, I think that, he's able to look at that and delineate it a little bit further. If it's a primary RV, even if the LV is down, I'm still going with low dose epi is usually my kind of primary go-to drug. I don't think we'll have time to go into much about utilization of vasopressin, but that one's a pretty hot topic in terms of vasopressin's a really great drug for our primary RV disease babies with pulmonary hypertension, but we always worry about the LV and those kids. And so I tend to start with low dose epi, but that doesn't always help your blood pressure or your diastolic blood pressure get higher. It just hopefully will help your squeeze. And I don't know what other people's thoughts are, but that's usually kind of my go-to. And I start nitric and then I reevaluate. And I think that's really the most important part of this talk is that you keep reevaluating to try to see how your baby is progressing. And usually within that second evaluation, I'm able to have a better understanding of what is the primary ventricle that's driving the disease process.
100% agree. I would tell everybody to go read Reagan Geisinger's paper from 2016 that Gabriel highlighted. It's in his talk, and I'll hand it back over to the moderators. Gabriel, what a wonderful presentation. Thank you for including all of us.
Thank you.
Thank you, guys. So we are at the end of our time in this webinar. Thank you all so much to our speaker and panelists for this wonderful discussion. And thank you for all the audience for joining us. In the chat, you will see the link to the Neonatal POCUS Collaborative's website, where you can find this webinar along with all our prior webinar recordings. So just a couple of reminders that we will not have a webinar in April due to conflict with PAS, where we will actually have a Neo-POCUS meet and greet at the Sheraton Waikiki Resort on Sunday, April 26th, for those of you who are going. And you can find more information on the PAS app. Also join us for our next webinar on May 27th. Remember to subscribe to Neonatal POCUS Collaborative website to receive up-to-date information about the webinar and other educational opportunities. So thank you all for your time with us today.
Thank you so much. Thanks, everyone. Thank you for having me. Blah, blahing too much.
Great talk as always, Gabriel.
Thank you.
Thank you all.
Thank you.